Welcome to the Athletes Performance Podcast, where two performance minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
First episode of the Athletes First Performance Podcast. I figured we'd start out with a little bit of an introduction. So, you want to just tell us about your background, where you came from, everything like that?
Yeah, so I'm James Zotto. I'm from Libertyville, Illinois, which is about 30 miles north of Chicago. Grew up there, went to high school there, and ended up going to Wofford College in Spartanburg, South Carolina. Got my biology degree and played football there for 4 years. And after that, went to the Medical University of South Carolina for doctorate of physical therapy program, which is where we met, and then was there for 3 years. After that, went to the University of North Dakota to complete a one-year sports residency program. That was from 2017 to 2018. Got a lot of good experience working with the athletes there and getting a lot of good mentoring. And then over the next year and a half, was working in the Sports Performance Center down in Columbia, South Carolina, Apex Sports Performance. And now for the past year and a half, I've been back up in Grand Forks, North Dakota, working for an outpatient orthopedic physical therapy practice. How about you?
Sweet. So my name's Josh Fisher. I was born and raised in Charlotte, North Carolina. Went up to Appalachian State University in Boone, North Carolina for my bachelor's degree in exercise science, and then went straight into physical therapy school at the Medical University of South Carolina. As you said, that was where we met. After I graduated, I went up to Wisconsin. I was in Appleton, but I did an orthopedic residency with the University of Wisconsin, and then came down to South Carolina, back to Charleston, and have been working in an outpatient clinic since that time. It's kind of nice because I think though we obviously have similar education backgrounds in regards to PT school, but we sort of taken different routes in focus, with you being more of the athlete focus and me kind of being more of the general population. But it gives us a balance because I feel like I've been had a little bit more work with the weekend warrior, where you've been a little bit more with the higher level athletes.
Yeah, it'll give us a good balance in terms of experience with high school, college athletes, weekend warriors, and kind of mix in our treatment philosophies that way.
Yeah, so today's topic is going to be on Achilles tendinopathy. We will start with just talking about a quick review of the anatomy of the tendon, and go into the physiology of what occurs when Achilles tendinopathy happens, and then get into a little bit of the risk factors, exam, and then the bulk of this will be on the different treatment methods that you can go when treating this condition. And then we'll share a little bit of resources at the end, just if you want further knowledge on the topic. So I guess I'll get into anatomy, and then you can maybe go into the physiology portion of it.
Perfect.
Okay, so the Achilles tendon, it's the largest and strongest tendon in the body. It arises from the gastroc and soleus muscles about equally, with the soleus portion of the tendon being more anterior to the gastroc portion. It inserts down at the calcaneal tuberosity, and it's surrounded by two bursas. So there's a retrocalcaneal bursa, which is anterior to the tendon, and then there's like a superficial bursa posterior to the tendon. It doesn't really have a synovial sheath like most tendons do. It has what's called a peritoneum. The peritoneum is a flexible connective tissue that allows gliding of the tendon. And of note, like most tendons, it's not highly vascular, but the peritoneum is very vascular. And it's innervated by local cutaneous nerves, and in particular the sural nerve, which we'll get into with differential diagnosis. As far as vascularity goes, the least amount of vascular area where the tendon is about 2 to 6 centimeters above the insertion, which is about where that mid portion Achilles tendinopathy occurs. So possibly related there. And it can handle quite a bit of load. So when running, it's going to have up to 12 and a half times body weight load on the tendon, and then with walking, it's about 3 times body weight. So yeah, it's pretty strong tendon, highly used with athletes, particularly running athletes. And James, you can get into what happens or how Achilles tendinopathy occurs.
Yeah, so ultimately, the result of repetitive overload with failed healing is what leads to tendinopathy. In terms of layperson's terms, and a lot of things that you'll hear with like recreational runners or athletes is a tendinitis, which means more of like an acute inflammatory condition. But with the research over the past 10, 20 years, they've really discovered that there's really no inflammatory condition with tendinopathy. It's a result of the failed healing. So that repetitive overload of running, jumping, sprinting, change of direction really changes what the tendon makeup is.
The word tendinopathy really describes a spectrum of changes that occurs in a damaged or diseased tendon. And an altered tendon consists of fragmented collagen fibers, disorganized collagen bundles, accumulation of glycosaminoglycans, and increased microvasculature associated with neoinnervation. And this is what we think is really causing the increase in pain, is the ingrowth of nerve fibers into the tendon.
And in terms of performance, with this chronic repetitive overuse type of injury, leads to changes in the tendon stiffness and strength. So in terms of sprinting and jumping, we want a stiffer tendon to increase force output. But with that chronic overload, there's decreased force, and then also affects the nervous system. So with that pain, decreased force, that central nervous system isn't going to be able to fire at its optimal rate. Ultimately, what we need to do is start loading the tendon, which we'll get into later on in this podcast.
Yeah, so essentially, obviously, just like any injury, you're going to have that type 3 collagen laid down like as a patch, just quickly, like the patch, kind of like patching a hole in a boat that's leaking almost. And then the healthy tendon, that's going to turn into type 1 collagen and restore that parallel formation, which is going to help return its ability to withstand load and produce force and absorb force. And then in that unhealthy tendon, you just don't get that. And more type 3 collagen is laid down, which then leads to decreased load tolerance, which kind of gets into a vicious cycle. But yeah, so who gets Achilles tendinopathy, James? Like what type of athletes or just general population of people are going to see this in?
Yeah, so in terms of specific sports, we're more likely to see Achilles tendinopathy in sports that require highly repetitive running or jumping. So you can think of athletes in cross country or track and field in terms of their running, and jumping with basketball, volleyball, and a little combination of both would be soccer. So all the running, change of direction, jumping, and the cleats and the change of surfaces that we're talking about. So in terms of some statistics, the annual incidence for runners is 7 to 9% per year. And with lower extremity tendinopathy in general, there's 10.52 per 1,000 persons per year, which exceeds the number of people that have arthritis. So it is out there and it's very common. And we know with just the decrease in blood flow and poor healing rate with tendons, there's an increased incidence with age. And in the research, it's most commonly occurring in athletes or people 18 to 65, but can occur in younger athletes in sports that we said before. And it's very common in weekend warriors. So you can think of mid 40s that are still trying to stay active, but they just try to do everything on the weekend with that high repetitive load, and they don't get a chance to recover and heal.
So when we went through the literature review, when you get into risk factors, I feel like there was just 1,000 different risk factors that you could find, and they all could be attributable to Achilles tendinopathy. But the ones that I saw most frequently and are probably most supported is going to be, as far as extrinsic risk factors, are going to be mechanical overload or a training error. And this is something that I would look for in the history if someone comes in with Achilles pain. I'm going to look at what their training was prior to the issue and where they're at now, and has anything changed that could have created that mechanical overload at the tendon. Because you're going to be either going to be one of two things. It's either you increased the activity that you did, or you increased your activity, which overloaded the tendon, creating this cycle, or maybe you were sedentary before getting back into running for weight loss or something like that, where the tendon's tolerance is just so low that this cycle began, and it doesn't have a great healing process just because it hasn't been exposed to those forces lately. Some other things as far as extrinsic risk factors, excessive hill training, training on harder slope surfaces. You may see a change in surface from maybe a soft surface to a more firm surface. Changing in shoes, particularly in running. If you kind of move to a lower heel drop, you're going to see more force on the tendon just because you're going to be more peak dorsiflexion at mid stance. So things like that could lead to this basically by increasing forces to the tendon unexpectedly. You can look at their footwear. You may see uneven wear, maybe caused by excessive eversion in the stance phase. And then also if an athlete has had a change in season from off season to in season or vice versa. James, you want to talk about the intrinsic risk factors?
Yeah, so some of the more common intrinsic risk factors that we see are increased age or like a decrease in blood supply to that tendon. We know that the tendon doesn't get a lot of blood supply, but with increasing age, there could be even less. Extremes of either decreased or excessive dorsiflexion. So decreased dorsiflexion, I think, is pretty common in most people that we see, kind of just alters the biomechanics. And then something that I was a little bit interested in was that excessive dorsiflexion. And from my point, you can correct me if I'm wrong, I think that excessive dorsiflexion just puts that Achilles tendon in a little bit more compressive position against the calcaneus. That's what I'm thinking. I don't know if you have any other thoughts on that.
Yeah, I was going to say, it's kind of funny how it says, decreased or increased dorsiflexion, because you're kind of like, well, where's the middle ground? And it's obviously person to person, but yeah, that excessive dorsiflexion, I would imagine, just puts a higher compressive force and probably is more related to insertional tendinopathy as opposed to mid portion.
Mm-hmm. Yeah, so that's one thing that I thought was pretty interesting. And then going forward, so altered neuromuscular control and just general lower extremity weakness, especially plantar flexion weakness, can definitely increase more load on the tendon. Specific drug treatments, I can't really pronounce this, pretty like fluoroquinolone. So any type of antibiotic, that's pretty well known in the research, that's prone to decreasing tendon strength and increasing pain. Prolonged steroid use, corticosteroid use, different types of hormone replacements. So middle-aged women that are kind of going through menopause, that might be an increased risk factor for that type of population. Specific statins. And then metabolic conditions like diabetes, hypertension, obesity, and then possible genetic factors too. And just kind of going along with the different metabolic factors, I think something that we should be talking to every athlete or patient that we're working with is just the influence that nutrition, hydration, sleep, and recovery plays in this. So just like almost anything that we do, we should be talking to our patients and athletes about those specific things to improve recovery and help the healing factor as well.
Yeah, and then obviously those are, the fact of the matter is with the tendinopathy, particularly one that's been long-standing, is you kind of have a failed healing response. So you need to have the recovery, and sleep and nutrition play a big role in that. And also don't be afraid to reach out to a dietitian that may have or will have more knowledge in that, particularly in that nutrition realm than we do, just to make sure the athlete is getting what they need. I'm pretty big on like you can kind of go out and say, you need to eat this and that or to recover or drink this afterwards or whatever. But there's a pretty distinct science to it, I feel like, and it's definitely individual. So just being comfortable with saying, that's not, at least with me, that's not my area of expertise. So reaching out to somebody that knows about it a little bit more is probably going to give that athlete a little bit more accurate information than, kind of dumping the general thought process on what healthy is and what is appropriate for recovery.
Definitely. So moving on to the history and the physical exam, do you want to take us through what types of things that you're asking the patients and what types of things that you're looking for in their subjective history and exam?
Yeah, so I'll kind of give a background on how I like to do my exams, and then just how it relates to Achilles tendinopathy. So I place a heavy emphasis on the history. It's probably the majority of my evaluation, I guess you could say, and I think that's pretty important in this condition, just because as far as special tests go and things like that, there's not a lot that can be that useful. Um, but yeah, so starting with the history, my first, after we get through, symptom location and you go through the easing and aggravating factors and things like that, I like to get a good sense of if there was a change in volume or load that caused that or that preceded, I guess, the issue at the tendon. Just like some of the risk factors we talked before, um, if there was particularly volume or intensity change or surface, for example, running up hills versus flat ground, um, that's good to know because honestly, sometimes the treatment, if it's acute enough, is just modifying the training load and things calm down. Um, and then also taking note that it could be a combination of factors, and it doesn't have to just be the extrinsic factors that combine to create this. It could be that increase in load plus increase in stress, or someone could say, well, I've done this before, it's been no problem, but maybe they haven't been getting as good a sleep over the past month, things like that. So not just asking like the performance side of things, but also getting a sense of just what the daily life looks like, um, because you can kind of put a puzzle together. And some of the treatment that we'll get into, it can be as simple as just modifying that information and seeing a pretty good response outside of doing the typical physical therapy management. Um, you also want to get a sense of like the duration of symptoms. Typically, in an acute issue, things start to get better quicker. So most of the time, the quicker you see the person, the better. I'll also get a sense if they've seen anybody else. If they're coming to me direct access, um, or if they've been through primary care or orthopedics, and if they've had any imaging or anything like that. Um, that can help. And then just getting an idea of pain throughout the day, whether it's first thing in the morning, whether there's a warm up phenomenon, which is consistent with the tendinopathy. Um, and then you can get to the examination. I'll kind of let you take that part because I feel like you're going to get into that functional testing that you're going to do more with the higher level athlete. So what do you do, I guess you could say, on the table, and then what are you doing functionally to test these
So
patients?
probably the first thing that I'm going to do is just look for the location of the pain and palpation. I usually don't do that with most of my physical exams, but in terms of the tendinopathy, it's pretty easy to determine, okay, if they have increased swelling and tendon thickness in a specific area and their tentative palpation, I'll just take a look at that really quick. So I'll look at the location where it is in terms of like mid portion or insertional or things like that. Then I'll also get a pain pressure threshold. So there's some research from like Karen Silbernagel um, explaining that getting that pain pressure threshold. So maybe that first day, if they're at a 7 out of 10 pain with touch or palpation, that should improve some with your treatment. It might not be completely pain free, but that's a good indicator of where we're going in terms of how well we're progressing. Also looking at general range of motion in terms of the ankle, hip, knee. I might do a little bit of manual muscle testing on the table depending on what level of patient that they are. So if they're not type of super high level athlete, I might just get some hip strain, things like that. But moving on to more of the functional exam off the table, I'll take a look at single leg calf raise. So how many times they can do it before pain or fatigue stops them. Depending on how acute or severe their symptoms are, hopping. So hopping on one leg, just like you're going to do a jump rope, but just on one leg, seeing the pain intensity and how well they can perform that. And then depending on if it's just happening with running, maybe taking a look at running. You're more of the running expert, so maybe not on that first day, but that's something that we'll definitely want to take a look at early on in PT if it's only happening with running.
Yeah, the running analysis thing is nice from just, if someone says it hurts to do X, you might as well look and see what it is. So if their pain is really only during running, as long as they can tolerate it, it's a good thing to look at. I think kind of narrowing your focus down on that mid stance position, because that's when the Achilles is going to be experience the highest load. It's in the most stretched position at that point and then has to push out of it. Um, yeah, I don't know if there's a ton of information, and I could be wrong on this about. Uh, I know you can manipulate stride and you can manipulate different things, but it's interesting because if you shorten the step length, you're gonna decrease that maximum dorsiflexion that they're gonna experience in mid stance, but you're probably gonna push them more into a forefoot strike, which will load the Achilles tendon, but you won't have that same compression. So it's I think that's something that there's smarter people than me that talk about this, but to me that would make sense to you can do that treatment based on whether it's insertional or mid substance. So I would think if you want to reduce compression, then maybe shortening the stride is good. But if you have more of a mid substance issue that's just not as tolerant to load, shortening their stride via increasing their step rate may not be as effective. Just in my head, that's what would make sense. But going back to some of the tests you do, when you say you look at, are there any? I know you said you do a manual muscle test or of some sort, just testing strength, maybe on the table of like the hip abductors or something like that. What do you look at above the foot, um, as far as maybe what we'd call the kinetic chain that may influence the
Yeah,
treatment that
so
you
I'll
do?
probably start with something like either a single leg squat to a bench or standing on like an 8-inch stump and doing like a heel tap, either forward or lateral. So that gives me a good idea of their movement strategy. So if they're more hip dominant, more knee dominant, if you're seeing a valgus knee positioning, so maybe thinking, okay, they have poor control of their lower extremity. So that would probably be the first thing that I'll look at. And then moving on to a Y balance test. So that's a little bit more objective. You can get some good numbers that first day to determine, okay, how well are they able to control their single leg stance and neuromuscular control, reaching forward, diagonal laterally, and then diagonal medially. So good numbers to compare later on in terms of how well they're progressing with that neuromuscular control. And then if they can handle it, maybe looking at that single leg hop in place. So that's one of our assessments to determine, okay, is this actual Achilles tendinopathy? Because if they're able to hop in place without pain, maybe we're thinking something else. And then also this might be more for discharge testing, but like a single leg hop for distance or a single leg hop for height, measuring again how high or how far they can jump, their landing mechanics, and just assessing their overall kinetic chain and single leg positioning.
Okay, yeah. So that's one of the things too. I remember coming out of PT school. It was like test this, test that. It's positive or negative. I wouldn't really take into account the performance of the
Mm-hmm.
test, I guess you could say. Even if it's just palpation, like you said, like that tenderness to palpation should be decreasing, and that's a sign of progress. And then using all these other tests, whether they can or can't do it, they're retestable. So like the single leg calf raise, they go to fatigue and um, they can't do as well on one side versus the other. Then that's something you can retest. Now, looking at the research, and I believe this is from Seth O'Neill, one of the problems with testing some of these things side to side is you're going to see um, bilateral weakness possibly with these patients. They've done studies where um, they're going to compare healthy controls versus the symptomatic and the non-symptomatic legs of the patient that has Achilles tendinopathy, and they don't see a large difference in strength or force output with the patients with tendinopathy. So you have to be careful testing um, side by side. I mean, I think it's
Mm-hmm.
worth looking at for sure, but if you see something that is like, for example, on the single leg calf raise, if you see something that is pretty similar side to side, um, I don't know how you would measure this, but kind of get an idea of like, what their tendon has to handle and the activity that aggravates them. And if it just seems, like if you have a runner that can only do 5 or 10 single leg heel raises, um, and that's bilaterally, then
Mm-hmm.
they probably have weakness. And it could have been because of the tendinopathy, or it could have just been they're weak and could have been the cause of the tendinopathy. There's really no way to know. But that's just
Yeah, and you
something to
can
keep an
always
eye
look
on.
at the normative standards too. So you should always, in terms of what I look for, you should be able to do more than 20, ultimately more than 25 single leg heel raises if you're running or if you're an athlete. So looking at that normative data too. And then you can use the Y balance test. There's different normative values there in terms of your own limb length. And then they have normative values for like high school basketball players, volleyball players, military. So you can always take a look at that to see how well they compare to their peers.
Yeah, no, that's a good point. And to be fair, 25 single leg heel raises that's pretty difficult. I mean, most strong athletes should be able to handle that, but with a weekend warrior type of person, 25 good and smooth, equal height single leg heel raises is no joke. But yeah, so you want to get into the differential diagnosis and things that you are trying to rule out in order to rule in
Yeah.
Achilles
So
tendinopathy.
one thing that I didn't talk about in my exam, I'll still take them through like a standing. Something that I like to do is like the selective functional movement assessment. So the first thing I'll do before they even get onto the table is go through those 7 movement patterns. So that'll help clear something like a radicular lower back pain. So you're taking them through multi-segmental flexion, extension, rotation. And if they get their familiar posterior leg Achilles pain with lumbar flexion, then I'm thinking, okay, maybe we need to take a look at something else besides just Achilles tendinopathy. So that's something that I forgot to mention early on. But looking more directly at the foot and ankle, so retrocalcaneal bursitis, so pain anterior to the Achilles, looking at a positive squeeze test, so just squeezing that area to see if that produces their familiar pain. Posterior ankle impingement, so a lot of times we see anterior impingement with pain on dorsiflexion, but now we're looking at pain with full plantar flexion range of motion. So that's pretty common in dancers or gymnasts, someone that's super mobile and has to get into that position quite a bit. That's something that I'm thinking in the back of my head. Irritation of the sural nerve, plantaris tendon involvement, insertional Achilles tendinopathy, which would be more so pain and stiffness over the calcaneus Achilles insertion versus that mid portion Achilles tenderness and pain.
Yeah, and just to go back to the sural nerve piece of it, you can obviously you can screen the low back and you may see something there, but you can also do some neural tension testing just to see if that reduces the pain. But I mean, you're going to see a lot of those functional tests possibly that don't react to, or they don't recreate the pain in something that's more of a nerve issue. I imagine that's very few and far between, but just something to keep in mind. And then the plantaris tendon involvement. The plantaris muscle doesn't really do a whole lot. It's more of an assistance muscle to the gastroc soleus. I think I read that they kind of think that it might just be more of a proprioceptive, or the tendon's more of a proprioceptive thing, just to give you a sense of where the knee or the ankle is, than actually producing much force. But it's going to run similarly to the gastroc as far as action goes. And if you have plantaris tendon involvement, you may see more medial sided pain, just because that's where the tendon runs. So you just may see a little bit more medial sided pain than traditional insertional or mid substance tendinopathy.
Okay, so I feel like we've got a good understanding of the population that gets Achilles tendinopathy, the different risk factors, went through our differential diagnosis, history, and exam. Do you want to give us a little idea of what you're looking to do while treating these patients, what types of exercises that we're doing here?
Yeah, I think coming out of school in the traditional kind of Alfredson's protocol is going to be eccentric exercises. The general sense is working 2 times a day, 7 days a week, and performing 3 sets of 15 of 3 different exercises that load the Achilles. So one's going to be a unilateral heel raise off a step, so into a deficit with a straight leg, and then with a bent leg. Now you're going to look at a 3-second lowering, so a 3-second eccentric portion. There's rest. It's probably going to be to tolerance on the patient, but the general in one of the articles, when they compare eccentric training to heavy slow resistance, the rest is going to be about 2 minutes between sets and 5 minutes between exercises. And in that article, in the American Journal of Sports Medicine, 2015, Bayer et al., they compared eccentric to a newer form of treatment called heavy slow resistance, and they didn't find much of a difference in regards to outcomes, but they had a short term in the first 12 weeks of better patient satisfaction with the heavy slow resistance. So do you want to get into that, kind of how they work?
So the heavy slow resistance protocol was performed 3 times per week, doing 3 exercises of 3 to 4 sets each. So the 3 exercises were more gym-based equipment. So a seated heel raise on an exercise machine, a standing heel raise in a Smith machine, and then a straight leg calf raise on a leg press. So you're performing 3 to 4 sets of those in a specific progression. So it starts by 3 by 15, progressing to 3 by 12, 4 by 10, 4 by 8, and 4 by 6 over a 12-week period. So kind of like you were saying, in between each set, there's a 2 to 3 minute rest and then a 5-minute rest between each exercise. And the biggest thing in terms of tendon is the loading. You want time under tension. So the tempo here was 3 seconds up, 3 seconds down. So you're still getting that good eccentric, but you're also getting that slow concentric portion, creating more time under tension. So I think the biggest thing here, similar outcomes, but the big thing in the paper was better patient satisfaction with the heavy slow resistance program. So in terms of total tendon load time, there's only 41 minutes per week, and total time with the program is 107 minutes per week with the heavy slow resistance. And comparing that to the eccentric, you're doing 63 minutes per week, and then the total time with the program was 308 minutes. So I don't know about you, but I don't think I would stay consistent with that full eccentric program 2 times a day, every day, doing those same exercises. I feel like that'd kind of get boring and just get so monotonous. So in terms of what I prescribe personally, I'm more so inclined to use that heavy slow resistance training as long as we're able to use the equipment in the gym, or they have access to that type of equipment or weights in the gym.
Yeah, and you, just to be fair, that heavy slow resistance was heavy. So every time they would do their 3 sets of 15 or 3 sets of 12, it was a 15 rep max, which is why the rest was what it was, which is typically about the rest that you would see when you're focusing on kind of hypertrophy work into strength. But it was, I mean, it's heavy. So that 15 rep max means you're toast at 15. So while the loading time and the time it took to complete the program was lower, possibly higher intensity. I mean, not as high as volume, but higher intensity. And I agree. I think the heavy slow resistance would be the way to go, pending all equipment available. I think the eccentric is good, and it's a good thing that they both produce same outcomes, because if someone doesn't have the access to those weights, or just is inexperienced with loading themselves to the point of failure, basically at 15 reps or so, the eccentric protocol can be helpful, because all you need is a step. Though you have to try to stay consistent with the program. But I mean, who knows? 308 minutes a week was how long it would take, or doing it 7 days a week, 3 sets of 15. That may not even be necessary, or it may not even be tolerable. And that kind of would lead me into another loading scheme that you can try. And I'm going to ask you in a second, James, about how you may implement your that triphasic training that you talk about sometimes with this, if you think that would have a role. But with isometrics being the third type of contraction, there's been studies in patellar tendinopathy that showed that doing a high load, about 70% of your MVC, and holding it for about 45 seconds can reduce pain post-exercise. So they did that same study with Achilles tendinopathy and didn't see a change. in pain or in motor output. So the question is, are isometrics beneficial? And in my opinion, I would say, yeah, they're probably beneficial, particularly if someone can't tolerate heavy slow resistance or eccentric training. It could be a nice way to get low to the tendon comfortably. It could be a form of great exposure, particularly in someone who may have had this for quite a while and have started to change their movement patterns because they don't want to load the tendon. So I think the isometrics could be useful. They should be heavy, particularly if they're tolerable, and then transitioning them into that either heavy slow resistance or eccentric training. And one other point with eccentric training that I thought was interesting was, I guess you could call it heavy slow resistance too, but in order to increase the time under tension on the tendon, I was listening to Seth O'Neill on a different podcast, and he was talking about doing variations in depth. So maybe you go down to 50% depth and you come all the way up. Then maybe you go down 25% and all the way up. So you're kind of varying how low you're dropping your heel off that step back and forth. And it can increase time under tension, but it can also improve motor control. Because like you said, in the presence of pain, your motor control is probably going to decrease. So having someone, whether using a metronome or just telling them or to have them react to, like, as they slowly lower down, tell them to come back up. So they let them go all the way, let them go 50%, just vary it to challenge the tendon, but also to challenge the motor control, which I thought was interesting. But yeah, so you want to give a background on triphasic training? Because I was interested in asking you this. I know we've talked about it a little bit, but you want to give a background, and I'd be interested to know if you think it has a role in
a good
treating some of these
idea. So
patients.
Cal Dietz, who's the strength and conditioning coach for the University of Minnesota, in particular, their hockey team, and I'm not sure if he does more than just hockey, but he wrote a book called Triphasic Training. So the whole premise of triphasic is working on the particular 3 different muscle actions. So eccentric, isometric, and concentric. So that's something that I've been playing around with a lot in terms of creating my rehab plans, because in a normal gym type setting, everyone wants to produce power. So they're going as fast and as hard as they can on the concentric portion, but all the money is made with that eccentric and the isometric contraction. That's where you're really going to build that good tendon and soft tissue health, and with isometrics, building that true strength fast. So I think it can definitely be worthwhile if you're doing more than just heel raises. So something with like a split squat with a heel float position, doing 3 weeks of heavy eccentrics, going down 3 weeks of heavy isometrics. So with that eccentric, taking like a 7-second eccentric. And then if you're loading heavy enough, so what he does with his hockey players, he does super maximal load. So he'll have someone in a split squat with the bar on their back, like a safety bar, and he'll have 2 people on each side, 2 of their teammates on each side. So the athlete will go down 7 seconds and it's super maximal. So he's not able to push that up. And then his teammates will help raise that bar with them. I don't think we're doing that in rehab. Maybe we are with higher level athletes, but just getting heavy eccentrics for a 3-week block, heavy isometrics for a 3-week block, and then adding in that concentric. So adding in that explosive concentric portion of a 3-week block is something that I think if you're doing it in training, you might avoid some of these issues because you're getting that proper tendon loading. But in terms of creating a tendinopathy rehab program, maybe not for an acute tendinopathy that's super painful, but as you're progressing these athletes out into more of their sport specific programming, using that triphasic model in conjunction with different types of plyometrics and jump training is something that would be a great idea and great model.
Yeah. And I think too, like, and if you look at, you have your leg press, you have a standing calf raise machine and a seated calf raise machine, particularly if you want to go single leg on it, you could kind of work on that overload positioning. Because if you use, if you're going to use either a seated or a standing calf raise machine, you can come all the way up with both, and then just the load is going to be too high for that one leg to perform the concentric action. So you could really overload there too. And I'm wondering if it's just as heavy as possible that they can tolerate. And that's what's going to create those changes in both pain, performance, and then actual physiologic changes to the tendon. But yeah, so do you want to get into that the clinical commentary that we found by Silvernagel also, and talk about it kind of proposes a nice return to sport progression that I feel like would give us a foundation of how to do this with certain people?
It's a great paper for anyone that's interested in working with athletes that have Achilles tendinopathy and getting them back to their sports or getting back to running. So I think the first thing that we talk about, and we haven't really talked about this at all, is educating the patient or the athlete on the healing process of tendons. So a lot of people think, oh, this is going to go quick. Couple weeks of training, I'll be good. But this is a minimum 3-month process, probably more of a 6 to 12-month process. So educating the patient or athlete on this is something that we have to deal with for the long run in order to help remodel these tendons, get your tendons strong, decrease pain, and get you back to performance. So that's the first step, is just setting the expectation. This is going to be a long-term type of process.
And Jay, would you tell them, like, how in depth would you go with explaining to them why it's going to take so long? Because like, if you just told me, for example, this is going to take 3 to 6 months, maybe longer, are you going to get down into because of the physiologic changes that have occurred? Or are you going to get, I guess it depends on the athlete, but how in depth will you go? Or maybe how surface level will you go with explaining to them
I'll go
why
into,
it's going to take that long?
I'll explain what a tendinitis is, or an itis, so an acute inflammatory condition or process. So I'll explain that part to them and say, okay, this is probably something that's been going on for a long time, and just that gradual progression of that tendon disrepair or altered healing has finally just shown itself. So it's probably been going on for a long time, and it's going to take a long time for that tendon to get reorganized and strong and less painful. So I'll go into the details of kind of what we talked about. I might not go into the full histology of it, but I'll explain what a tendinopathy is versus a tendinitis, so they get a better idea of that.
Okay. Yeah, that makes sense. I think sometimes just giving them an idea of how long it just takes the body to adapt to things. Sometimes I'll compare it to trying to gain muscle. It takes time and it takes consistency, and you're not going to see a huge difference within, a month's worth of time.
The second thing is talking to them about pain. So there's a great pain monitoring model in most of these newer research papers on tendinopathy. So a lot of times in physical therapy, we're a little bit more conservative. Like, okay, we don't want to exercise into pain. We don't want to push pain. Pain is bad. And reframing that with the patient is super important, especially if they're fearful of that. And so there's a great model in red or a green, red light in terms of the numeric pain rating scale. So we call the safe zone anything between 0 and 2 out of 10 pain. So if you're feeling 0 to 2 out of 10 pain, you're good to go. We don't have to worry about that in terms of, do we need to change anything that we're doing in terms of exercise? An acceptable amount of pain is from that 2 to 5 out of 10 pain, which is probably more than what most of us are using in general physical therapy. So that's an acceptable zone. And then the high risk zone is anything more than that 5 out of 10 pain. That's when it's getting pretty severe and noticeable, and you can see the athlete or the patient kind of making faces or grimacing while they're doing something. So during activity, the pain is allowed to reach a 5 on that scale. Same thing. So we're going to go through 3 more. The pain after the activity is allowed to reach 5 on this scale. So that's either sporting activity or activities in terms of physical therapy or exercise. And then another thing that we need to monitor is that next morning pain. So pain the next morning after go past 5 out of 10. And then pain and stiffness is not allowed to increase from week to week. So as we gradually progress load and activity and maybe getting into plyometrics, that pain and stiffness in the morning or with that activity should not be increasing. It should either be the same with higher level activity or gradually decreasing as we get into level activity. The overall tendon process and that pain monitoring model, I think, in terms of helping these athletes and patients truly understand what they're about to go through.
No, that totally makes sense. I think I like the point that you said that going that 3 to 5 range of pain, the acceptable zone. I think we don't, and particularly like the people that I see, most of the time if they have this, they've had it for a long period of time, which in my mind will allow me to load it more, just because we know that there's no acute official damage that we'd have to worry about. Most of the time they've been through the health system for a while, so they've had plenty of imaging. But even still, I probably don't work them up to that, particularly like a 5 out of 10 pain. And I think that that's something to just be aware of, that it's okay to do that. Everyone's scale is different, so you have to show them this. But, as tolerable, I think is how I would do it just generally in the clinic. But yeah, if they're between a 0 and a 5, as long as it's not increasing week to week or it's not bad the next day.
Yeah. And something that I heard on a podcast from Karen Silvernagle was, if they're at a 4 out of 10 pain consistently, but they're able to do harder and harder activities, even though that pain's not changing, they're doing more and they're doing higher level things without that pain increasing. So that's a win. A lot of times athletes and patients are more so concerned about the pain, but you have to help them understand and see you're doing so much more than you were doing a couple of weeks ago, and that pain hasn't increased. So that's a win in our eyes. So people think it's all about the pain, but look at the function as well.
I guess I'll get into how the return to sport, the proposed return to sport, and this is for mid-portion Achilles tendinopathy, but you can kind of modify it, and I'll talk about that with insertional. But I'll get into kind of the step-by-step that they do for monitoring and progressing the patient back to sport. And I'll let you kind of get in more to the high-level stuff, since that's what you've seen more of. But just like you said, step one, you're going to educate on the healing process and just the timeline of how long it's going to work and how they should monitor it. Once you get into step two, they used a way to classify activity based on light, medium, or high. And then if the patient classified a particular activity as light, medium, or high, it dictated how much rest they would take between the activity. And it also dictated, there's definitions on what you consider light, medium, or high, and it was based on pain level during the next day and their rate of perceived exertion. So to not get too deep into it, because I think the paper is really good that you should check out, the light activity is going to be 1 to 2 out of 10 pain during and the next day. The medium is going to be a little bit more pain at 2 to 3 out of 10, and maybe a 3 to 4 the next day. And then high pain is going to be pushing that acceptable zone during the activity, but then maybe quite a little bit beyond it at 5 to 6 out of 10 the next day. The RPE will vary, but a light activity is going to be 0 to 1. A medium activity will be 2 to 4, and a high activity is going to be 5 to 10. And the idea is that as they go through this return to sport process, they'll retest this classification of each activity about every 3 or 4 weeks. And you're hoping that what someone maybe considered a high level activity the previous session has now reduced to medium. And then you can start to add a new higher level activity. And we can get into eventually, maybe in the form of a runner or a different athlete, how we may progress light, medium, and high. But it's a good way to, I think monitoring this is huge, and it's a good way to monitor. And it includes the patient's perspective on not just pain, but how hard they think the activity is. And the way they suggest recording it is having the patient use a training diary and writing that stuff down, because then you can really track progress. And I think particularly with an athlete, they like to track their progress. They need to visualize the improvement. I tend to like working with the running population, since I have a bit of a background in long distance running, and one of the leading guys on running in the physical therapy profession is Rich Willie. He had a presentation, and it was basically, again, another step-by-step process of how you could return a runner to their sport, particularly a long distance runner. And I think, as you've seen before, I really like the categorization of these step-by-step processes, because it just helps. If you have a process, it can become flexible, but it gives you a baseline. So step one, like we already said before, you're going to educate. I think it's also good to understand the particular person. So if you have a marathoner versus a weekend warrior, maybe you have someone who focuses on 5Ks, it could be a triathlete. Anyone that has a foundation in running for their sport, you need to look at the cumulative loads, the peak loads, and the rate of loading. The cumulative loads are nice to track, because if you just get an idea of you can become really mathematical if you can get an idea of their basically time on their feet running per week. You can start to get a sense of how much load that Achilles tendon's getting. And if you see an increase or a decrease, you can just find the numbers, and you'll be able to tell how much of an increase or decrease it was based on the time on their feet. But once you educate them, step two is going to get into that loading. So however you want to do it, he suggests heavy resistance training. And I think for runners, that's probably a good way to go, just because they tend to not prioritize lifting. I would say, just anecdotally, you probably have to be careful and watch for other possible issues if it's something that they're not familiar with. But you want to go heavy, use that pain monitoring scale, and continually assess their pain during and after. He suggests using a calf raise, straight and bent leg, so kind of like the eccentric protocol, progressing from double leg to single leg. The other piece of that is, if they can't handle the heavy load at first, you may need to reduce the loads. And I think I talked about before, looking more towards a high drop shoe or a heel lift to just get off of that or avoid that deep dorsiflexion when you're in mid stance. Or you could also use a rocker bottom shoe, which is going to help reduce the need to push off in that late stance period. You can check, and I think we said this before, you can check tenderness to palpation as another way to look at their progress, but they shouldn't be very tender once you get to step three, which is going to be plyometrics. And when you get into plyometrics, his what he said was to use progressing from a step squat to a double leg squat jump with a single leg land. And you're basically progressing your plyometrics from double leg to single leg, and then increasing volume or increasing repetition. So maybe going from a single leg jump to land to maybe 2 or 3 times single leg. So you're just jumping off the leg 3 times. In order to get to the plyometric phase, he recommends being able to do 3 sets of 8 of single leg heel raises with 20% of your body weight as load. That's obviously a general number, but it's something you could set a baseline for. And if they can do that and they tolerate plyometrics, then you can progress to that. Once you get into running, I think one of the best ways to return running, and runners typically don't like walking, but utilizing walking and running, a walk-run program can be pretty helpful and can really help you control the loads the Achilles are getting, and you can increase it systematically. You're still monitoring your pain like you would when you're doing heavy slow resistance or eccentric training. But as they tolerate, you can progress the volume to the point where they're comfortable with the mileage that they're on. And then you can start to add in some of the different, tweaks to what they're doing. So whether they're doing high intensity, such as intervals or speed work, or they want to add in hills, or you change the surface from hard to soft, making sure you're not doing it all at once, but just sprinkling it in as they tolerate, I think is a good way to do it. Do you have a different idea for maybe
I would use a lot of that same model.
Or field athlete?
Having that good single leg heel rise with that 20% body weight, I think that's a good standard. That, or along with the 20, 25 single leg heel raises. I think that's great. And then that general progression, you can use that with anyone in terms of the plyometrics, going from double leg to single leg. I think something that we haven't talked about yet is progressing from slow to fast. So being able to properly transition from that heavy, slow resistance training to faster movements, because we know with faster movements, it's going to load that tendon more, because that's what the tendon is able to store and release that load quickly. So being able to train that without flaring them up is probably going to be one of the harder transitions, moving from the pure strength to the plyometrics. So something like standard double leg pogo jumps, if they need a little bit more help hanging a band from like a squat rack and just using that band to help pull them up and decrease that stress during their pogo jumps. So going from 2 legs to 1 leg with those pogo jumps. Don't forget about like your A skips. So like skipping, like A skip, B skip, C skip, bounds, starting from slow and progressing speed. Just because athletes aren't going to need to, unless they're like soccer players, they're jog quite a bit. But in terms of transitioning from not sprinting to sprinting, going those skip progressions is super helpful. And then when I'm working with an athlete, I'm not just focusing on just the Achilles, kind of like we talked about. You're looking at that whole kinetic chain. So you're doing your heavy squats, lunges, deadlifts, anything that they're doing in their normal training program. So just keeping that entire lower limb strength is going to be super important to help, again, decrease some of the load on the Achilles.
Yeah, I think too, and another point of that is trying to maintain whatever their training regimen is, whether it's in season or off season, trying to maintain that as much as possible that doesn't involve the Achilles tendon, because that can be a problem. Like you rehab their Achilles tendon, but they haven't been performing their program for however long, 3 to 6 months, and now they have to not only get back into sport, but they also have to get back into their training, whether it's weightlifting or conditioning or anything like that.
Yeah, so we actually have an article about that. Like, do you have to stop exercising or training if you have Achilles tendon pain? And they compared groups going through Achilles tendinopathy protocol, either maintaining their normal training using the pain monitoring system or protocol that we used, or holding off on their activity for 6 weeks while doing their loading program. And there were no differences in terms of the outcomes. So as long as you're using that pain monitoring model while they're running, jumping, playing their sport, they can keep on going. So that's something that I did early on, is like, oh, you have to stop exercising. And then they get super detrained, and then they have to come back even harder after that. So they can keep on working on their program as long as they're not getting above that 5 out of 10 pain during their exercise later on or the next morning.
Yeah, and I think knowledge of that is something that could really set you apart when you're working with these athletes. The whole goal is to get them back to their sport as fast as possible. Obviously, there's time limit, particularly when you're trying to, create anatomical changes to a degenerative tendon. But if you can maintain their conditioning while they do it, it's going to set you apart in being able to return them quicker. They're going to like you more, basically. But yeah, no, I think that's a good point. And I'll kind of air to you on this. When you get into some of the other treatments, the conclusive, I guess that'd be a better word, as far as blood flow restriction.
Yeah, so I really like blood flow restriction.
Do you want to talk about those?
I probably use it every single day in the clinic. The Delphi unit through Owen's Recovery Sciences. So we know that we've been talking about the tendons need heavy load. So anything above that 70% helps remodeling and improve that tendon stiffness. And there haven't been a lot of randomized controlled trials comparing heavy resistance or heavy loading and BFR. But this was a study out of Germany that looked to investigate the effects of BFR using 20 to 35% of 1RM compared to conventional high load 70 to 85% RM, and looking at the in vivo, or like the actual tendon properties, going through a 14-week period. So like I said, they compared the two groups, and then there was also a control group that didn't do anything. So they just got assessed before and after. And what they were looking at, the specific tendon properties tendon stiffness is, again, what we were looking for, the tendon to increase in stiffness, muscle cross-sectional area of the gastroc, and then just unilateral plantar flexion strength. And like I said, this was over a 14-week period. And what they did with the high load group, kind of like we talked about with that heavy, slow resistance training, they used 3 sets of 6 to 12 reps of a standing and seated plantar flexion strengthening on a machine, progressing load every 4 weeks, going from 70 to 85% RM. And then they used blood flow restriction using the standard 30, 15, 15, 15 protocol in terms of sets and reps, gradually increasing 5% of their 1 RM each week, going from 20 to 35%. Or they increased that 5% RM every 4 weeks, excuse me. And what they did is what I think that we should be doing for everyone, maybe not 1 RM testing, but either a 5, 8, or 10 RM testing in terms of adequately applying the appropriate load for each patient. So what they did, they took a 1 RM test in a standing and seated heel raise. So they warmed up 2 sets of 10 submax load, and then they gave them 2 additional warm-up attempts at a 3 and 5 rep max. And then what they did, they tested a 1 RM seated and standing heel raise through full range of motion. If they were able to complete that, they added 5 to 10% until failure. And so they did this every 4 weeks with the high load and the BFR group, just to make sure that they were loading appropriately. And in both groups, there was a significant increase in tendon stiffness, muscle cross-sectional area, and peak plantar flexion torque in the groups. So this is a great article. And granted, there was only like 17 participants in this trial, so not very big. But it shows that there is a possibility of having good effects of blood flow restriction training on the tendon. And a lot of people don't like the fact that you're not getting that heavy load, but there's so many metabolic conditions brought up in blood flow restriction training. If you're strengthening the muscle, you're probably altering the tendon as well. So I like the idea of blood flow restriction training. Like if they're so acute in like the early phase where they're not able to handle load, if they're just doing their standing heel raise or seated heel raise off a step or off a little plate, I would put the BFR on. One, it's going to decrease their pain because the BFR hurts so bad, they're not going to be able to feel their tendon. And 2, they're just getting all the metabolic effects and getting the effect of heavy strength training, even though they can't really load. So I'd be very interested in using BFR anyone early on in the process. Yeah.
Yeah, I guess I should clarify, not, and I don't mean to say sketchy or, I guess I mean not as well researched or as well understood as the eccentric and heavy slow resistance stuff. But it's been shown to work in different things. And I think I get a little bit skeptical maybe when, because BFR has been researching a lot of different things and it's almost always positive. So that's either really good, or maybe it's not a silver bullet. I don't know. But I thought the study was well done. And it is interesting. And I like the idea too, if someone can't handle high loads, which is a lot of the reasons why we would use BFR, like in maybe early ACL reconstruction rehab, it's a good way to go, particularly if strength is going to be one of the
go ahead.
Risk factors of developing Achilles tendinopathy.
Yeah, and just something, you don't have to do 4 straight or 14 straight weeks of BFR. Something that I was thinking after reading this article, maybe just using BFR for the first couple of weeks of just getting the patient comfortable with the exercises and without the heavy load, doing that for 3-4 weeks, reassess them. And if they can handle heavier load, load them up. So in terms of what Johnny Owens and their whole group says, use BFR, and once they can load, get rid of the BFR and just go heavy load, because there's better benefit, especially with the CNS being able to handle that heavy load, increasing the motor units and the firing. That's where the real strength comes in, with that heavy load, increasing that motor unit firing.
So if we get a dry needling, and we've both been trained in dry needling, but you have quite a bit more extensive training than I do. And I think just by the virtue of the population that I see, dry needling isn't one of the main tools that I use. But it has been shown to be beneficial with Achilles tendinopathy or just tendinopathy in general. Um, I guess I'll start with the
Yeah,
background, and you
yeah,
can maybe speak on how you use it or would use it with these patients. So it has a history of being used via injection prior to dry needling even being a thought in physical therapy. And the thought with dry needling is that prior, because there was a needle being passed through the tendon, and it would help. They weren't sure if it was just the needle going through or if it was actually what was being injected into the tendon. Um, so theoretically, if it was the needle going through, um, it may help disrupt the degenerative process by creating a bleed and inflammation, which hopefully can kind of get you out of that non-healing cycle, and help the tendon return to its normal state. Um, as far as the process with dry needling goes, what they recommend um, is what they call tendon fenestration, where you find the area of tendinopathy. I think they refer to maybe tendinosis, but to tendinopathy, and you insert the needle into the tendon and then pull out and redirect, to try to cover the whole area of tendinopathy. And it's done 15 to 30 times. So kind of think of it as you're just sort of like peppering the tendon with the needle. And again, just to try to reverse the non-healing response. They also, because they're trying to create inflammation, the process is to do that and then have the patient avoid NSAIDs and ice because they don't want to blunt the healing response. And they may even put off PT for a few weeks just to allow that to occur without disrupting any sort of healing response that maybe have caused by the dry needle. From my point of view, and I think I'm more critical of dry needling than you for sure. So I guess it's a good balance. But from my point of view, with this idea, is some of the things that it said were, to me, and again, I don't do this very often, but to me, I think would be hard to palpate because it's a lot based on palpation. Um, so it says the fenestration is supposed to be stopped when the tendon feels soft as the needle goes into the to the tissue. Um, someone who doesn't do it very often, I feel like that would be pretty hard to tell, particularly as you get into it. Like what is defined as soft, and um, taking it from the first time you stick it in, how hard does that feel? How does the tissue feel when you advance the needle initially, and then what is considered soft, and then trying to determine the area of tendinosis. Um, they say to do it by palpating a thickened area of the tendon. Um, and I guess with the Achilles tendon, it's pretty superficial as far as palpation goes. So you may be able to feel that, but in other people, maybe not. So again, from someone who doesn't do a lot of dry needling and doesn't have maybe those palpation skills, I feel like that would be hard to feel. But I think theoretically the idea makes sense. I mean, you're basically creating like micro damage to hopefully um, produce a healing response, and it has been shown to work, particularly when combined with um, physical therapy. So
so
I
I
mean,
think
definitely an
that's a
option.
very
You
kind of
can
like
kind of speak
mechanical
on how you
model
would use
going
it
through the
if you
tendon
want to,
and
James.
just doing the fenestration. I kind of think of this type of dry needling as more of a neural response, because we know that there's a neural response to tendon injury. So there's nerve ingrowth with increased sensitivity with neuronal pain mediators with the neovascularization, what we talked about at the beginning. So I think using dry needling as a way to change the different nociceptive pathways is something that I think that we're doing more so than the mechanical stimulation of that tendon. And I use a kind of like a semi-standard protocol with dry needling. I'm not going to go through all the different points on what I do, but you're sticking different needles through the tendon. You're also going through points on the gastroc and then hooking up to electrical stims. So from my standpoint, we're doing more from a a neural pain modulation versus the mechanical changing the tissue. I think it's more of the loading that will change the tissue, and we're using the dry needling to help decrease pain via the different neural responses and mechanisms. The way that I would do it would be you go through your normal warm-up, you go through your loading in the clinic, and then finish with dry needling. The only thing that I can think of that would make me hesitant to do this, especially in an athlete, is you want to understand their pain response to the exercises and the loading to determine where we're going the next session, if we need to decrease it, increase it. If you're doing the dry needling to decrease pain right after their session, you might not get a good understanding of their pain levels later on that day or the next morning. So you're kind of altering their pain responses. So that's the only thing I'd be hesitant with. If someone is coming in, they're not really active, they just want to get back to walking pain-free, I'll be sure to use dry needling with their loading. If it's more of an athlete especially in season, or if they're about to ramp up their activity, I don't know if I would do the dry needling because I want to understand their pain response to the loading and their running and their activities.
I think that's good because I know you dry needle a lot more than I do, but I think it's important if someone does like to use a technique, they don't just automatically use it for everybody. Certain things may be useful with certain people, and I think that's what makes a good PT or health professional in general is, if you only have one thing that you do and use it for everybody, it's probably not the right thing to do. But I think using it for certain people, that can be a good call. And when you dry needle for Achilles tendinopathy, because if you're trying to basically alter or change or modulate neural pathways as far as pain goes, are you in the
protocol
gastroc
that I
soleus,
use,
or are you getting right into the tendon?
Anywhere between 4 and 8 needles along the Achilles, so 2 to 4 on each side. I usually go about 3 on each side using certain landmarks, and then there's a few going along the gastroc. So the protocol has quite a few needles, maybe not doing that the first time just to make sure you're not overloading them, but if you're going to do the full protocol, it's quite a bit of needles going in, about 6 through the Achilles, and then a few up in the gastroc.
Okay. Yeah, and I think we should probably do a whole talk on dry needling and probably blood flow restriction training too. But yeah, no, that's helpful to know. All right, so this is going a lot longer than I thought, but it's good. We have a couple things left to talk about, and we kind of already talked about a little bit as far as looking at up the chain when dealing with Achilles tendinopathy. Do you have anything else to add there as far as treatment or management or examination as far as going beyond the foot and ankle?
A return to play testing battery in terms of determining, okay, is their Achilles, but is their entire lower extremity ready to go back to their sport? Kind of like ACL testing battery with the hop test and things like that. So something that I saw in one of these papers that we were reviewing is, number one, using an outcome measure. I don't think we talked about this, the VISA A. So that's been shown to be very sensitive with Achilles tendinopathy. So that's something that I know our clinic doesn't use that in particular, but if I have someone with Achilles tendinopathy, I'll print that out and have them fill that out and be able to use that as a standard outcome measure. But also in terms of what we're looking for with that full return to activity, full return to play, no restrictions, looking at a counter movement jump, just looking at their qualitative movement in terms of their shock absorption, valgus knee positioning, ankle collapse, trunk position. And then if you're lucky enough to have force plates, or I use something called My Jump app. So it's pretty much just you record them, and the software is able to determine their force and their power. And you can compare that to standard norms. So that's something that I've been using with ACL return to play testing, just like a counter movement jump. And then looking at like a single leg drop jump. So you're standing on a 20 centimeter box, you drop down on one leg, and then you jump up again, and then you land. Again, that's a little bit more aggressive than a counter movement jump. Maybe not having everyone do that, but if they're high school, college, pro athlete, maybe taking a look at that. And again, you can use that My Jump app to determine side to side differences in terms of power and peak force. And then something that's pretty simple is just hopping in place, almost like that assessment that we're talking about. So pretend like you're jumping rope, just hopping on one leg 20 times, making sure that it can do that without pain. And then something with testing plantar flexion, strength, or power. So I don't have anything in the clinic that can do that besides just loading up like a Smith machine or a leg press and just doing ankle plantar flexion, seeing how strong they are there, and then checking out an endurance test with like a toe raise. So adding 10% body weight, either with a weight vest or a backpack, seeing how many toe raises they can do or heel raises they can do right versus left. So those are the main things that I'm looking at that you can also include in your testing battery outside of the functional assessments that we looked at the beginning.
I think good point, and I forgot to talk about this, especially when you're doing the actual test for calf raise. There's an app. It's a calf raise app where you can, you can video them doing their calf raise, and you can actually like in real time put like a sticker or like a dot on their calcaneus at the insertion of the Achilles tendon, or you can do it in the video and it'll track its path and how it's moving, so you can kind of get an idea of their movement pattern. And I think, and I haven't used it in a while, but I want to say it tracks speed too, because it's based off time, which could be give you a nice look at how quickly they can come up and down. So yeah, there's a lot of good apps.
Yeah, I'll have to check that out. I'll have to
movement.
get that from you. That'd be
so for sure
good
look
to
into
have
some of those
instead of just eyeballing it. Mm-hmm.
Yeah, I think, and I like video in a lot of, particularly like landing activities. I like to video it and put it in slow motion because I think for one, it helps me see it better, but you can show the patient or the athlete too, and it gives them a sense of what y'all are trying to work on. So I guess we can finish up, unless you have anything else to add on that, but we can finish up with just how you may treat an athlete during the season and what you may do differently than if it's someone who is either off season or just out of sport at the moment.
Kind of going way back to when we were talking about the heavy isometric, I think that's a great way to start loading the tendon and building strength without getting that eccentric muscle soreness or that delayed onset muscle soreness, especially for an athlete in season. If you do something and then they're sore for the next 3 days and they can't run or jump, they're not going to be very happy with you. So doing heavy isometric, so something that I heard on a podcast, like heavy farmer carries in like a heel raise position. So just loading them up with dumbbells or a weight vest and just walking on their toes for a certain amount of time. Something like we talked about with the triphasic training, Cal Dietz calls it an ankle rocker. So pretty much the positioning is you have like a plate on the floor and you get up into a half or a full heel raise position, and you're just holding that isometrically. You can be in like a Kaiser squat machine. You can be in a hack squat. You can have a partner or the PT pushing down on them to increase the isometric load for a certain amount of time. That's a super athletic position. That's pretty much like their starting sprint or their deceleration position. So you're training and isometrically loading an athletic position, which will help the entire kinetic chain, but you're also loading that gastroc soleus and ankle complex to help build strength there. And then kind of just like the different exercise that we're talking about in the split machine or the Smith machine, isometric knee straight or knee bent heel raises. You can get into a split squat with the heel float position. You can get into a bilateral squat just with the heels up, just loading the gastroc soleus in the isometric position. And then in terms of conditioning, if they're able to continue to compete in their season and their coach is wanting them to do a whole bunch of ladder drills or extra running, they don't need to be doing that. So they can do something like bike intervals, or depending on the facility, like underwater treadmill running, just something to keep their conditioning up with decreasing the load on their tendon.
No, I like that. And then, as needed, pain relieving techniques, foam rolling, crossball, stuff like that.
Yeah, that was a little bit longer than I thought. So
are we good? I feel like we have gone through it all. I learned a lot just by preparing, but hopefully people learned something too. And I think just quickly to end, we can talk about some of the resources we use, or just some areas that people could look if they want to dive further into this topic. And I'll start. I have two main things I would say. Dr. Seth O'Neill, he is a professor at the University of Lancaster, and he also owns his own practice. But he has his PhD, and his dissertation was focused on Achilles tendinopathy. And he has like a ton of publications regarding the topic, and they're all pretty helpful. And I think he's pretty evenly keeled on and knowledgeable on the depth of the research. Which is nice. He is also in a few different podcasts. You could just search for his name on Spotify or iTunes. I think he's a great resource. And then we've talked about Rich Willie. He's kind of all things running, but he has some good talks on Achilles tendinopathy. And then I like to look at Chris Johnson's stuff. He has a practice. He's with Zarin PT, his own practice, cash based out of Seattle, Washington. But he also with him and a couple other PTs have started a group called the Runner Zone. And there's a Facebook page too. He has to add you to the page based on if you join the Runner Zone on his website, but it has tons of resources, all things running. But he has a particularly good resource that he just came out with that talks about Achilles tendinopathy. And then what I find to be most helpful is it goes through, I don't know, probably like 30 to 40 exercises, and it kind of ranks them in how much they load the tendon, or basically how hard they would be on the Achilles tendon. So it's a great way to see, or to progress your patient, if to progress them down the intensity of the exercises. So yeah, Chris Johnson, Rich Willie, and Dr. Seth O'Neill would be three guys that I would say.
I was referencing a lot of Karen Silbernagel's work. She is a PT, athletic trainer, and PhD out of the University of Delaware, and she does a lot of research on Achilles tendinopathy and Achilles tendon ruptures. And then another well-known name in the tendinopathy world is Jill Cook. She's a physiotherapist out of La Trobe University in Australia, I believe. We didn't really add a lot of her work, but she's another well-known name in tendinopathy research. So those are the two names that I can think of that you didn't mention. Yeah.
Yeah, I was going to throw in Jill Cook because I know she does all things tendinopathy, but she obviously has publication on Achilles tendinopathy, and I think she's considered like the lead person.
Good deal. Well, we can wrap it up there.
But yeah, I think we're good. That was solid.